Good morning.
Good morning.
Good,
Good afternoon. For us, good evening. So, how are you, Shanti?
oh, very good. First thing in the morning, Monday morning.
Monday
So it's
morning.
good to start the week. Yeah,
Yes.
like this.
Okay. So, after this, you are going to office?
Yes, yes. So
Yes.
usually we start around
Your
10 o'clock.
voice is very good.
By 9:30 we'll wrap up.
Ah,
Yeah.
you can hear my voice?
Yes, yes. I just wanted to, make sure I'm able to share my screen. Yes.
Yes. Yeah. We can just check.
Can you see?
Yes. Yes.
Okay.
Yes, we can see. Karen? Karen? So this is
Ma'am?
going, Shanti, I'll send you the YouTube, it is going in YouTube
Recording.
also. I'll be
Yes,
sending
ma'am.
the Facebook link also. You can send it
Yes.
to people whom you want. Yeah, Karen, shall we start?
Yes, ma'am, we can start now.
We'll start. Let people keep joining. Okay. Um, yeah, who's going to introduce? Who's MC today?
Sergeant will be introducing them.
Yes.
Good evening, ma'am.
Good evening.
Yes, ma'am. So shall I start, ma'am?
Yes.
Yes. Good evening, Dr. Shanti Rajshekharan, ma'am. So
Good evening.
yeah, about her. Presently, she works as a pediatrician at the Medical City of Arlington, Texas, USA. She holds the licensure of medical practice for 3 states: Texas, Washington, and Michigan at USA. She graduated MBBS in 1983 to 1989 from Stanley Medical College, Chennai, and has been awarded the gold medal Best Outstanding Student of the 1988 batch for her exemplary performance in her studies, and also passed out as a topper in the state of Tamil Nadu. She is a quiz winner of the IAP, volunteered at the National Service Scheme, and a regular blood donor at the hospital. After graduating her MBBS, she underwent a special training in community pediatrics and general pediatrics with a postgraduate diploma in child health. In 1996, she got an opportunity to do her internship at residency from St. John's Hospital and Medical Center, Detroit, MIUSA, as recommended by the program director and the American Board of Pediatrics. She got 1 year exemption for her excellent performance in the first year of her residence. Later, she went on to work as an attending pediatrician at Woods Pediatrics, Harper Woods, MI, USC, Galvanic Clinics, NI, USC, Sundaram Medical Foundation, and Madras Medical Mission, Chennai. She presently holds a membership for the American Academy of Pediatrics, USA, and holds a lifetime membership of Indian Academy of Pediatrics and Indian Medical Association. My hobbies are practicing yoga and playing veena. Ma'am, we welcome you for today's session, ma'am.
So very warm
Thank you
welcome
so
to
much, Sajid.
also, Shanti is basically, I would like to say a few words because of my close associations with Shanti. She's my best friend also. Very basically, she's a very, very good humanitarian. She's very soft and very kind, and a very, very helpful, very friendly. All the good positive qualities she has. Because being a professional, sometimes we don't find this kind of empathy. I would say she is both humanitarian and a professional. From her gold medals, we can understand what big brain, brainy she is, nerd she is, but she's very simple, very kiddish sometimes, very friendly. Uh, so with this nice intro, and she is also a very big philanthropist. She recently, Shanti, I would like you to share about Project Marley also. So the, yeah.
Sure.
Uh, so she started being in US. They want to come back and settle in India, in Chennai. So I think we are Chennai people are lucky, and Tamil Nadu. She's planning to start. She already started NGO sort of association to promote health and awareness for the autistic kids and the parents. She is within her busy schedule. She started working full-fledged. Once she comes back to India, I think we'll be having a very good, promising healthcare professional. And she believes a lot in team. And that's why she gave a recognition to me in Sundara Medical also. Otherwise, for a psychologist, there is no much, still it is not very good scope. But I think it's 15 years back, I joined with her in Sundara Medical. And she gave a lot of facelift for psychology, I would say. Thank you, Shanti. Thank you for accepting for this program. It is for the benefit of the students, also for the World Mental Health Day, with the theme of having it's no reaching everybody. That's main theme of this year's 2020's World Mental Health Day theme. So bringing more of awareness and health aspects. Thank you for sharing your time and your valuable experiences with us.
Thank you. Thanks, Sajjan, for the nice introduction. And thank you so much, Dr. Tenmuri. And we go a long way, more than 2 decades, and we are still in touch with each other. We talk to each other quite often. So it's nice to do this program again for University of Madras psychology students. It's my pleasure. And I'll start the program now. So a sound mind is a sound body. So we all need a very sound mind now, right now, with so much of uncertainty going on. And let me go ahead start sharing my screen. You can see the slide, yes? Okay. World Health Organization defines mental health as a subjective well-being, perceived self-efficacy, autonomy, competence, intergenerational dependence, and self-actualization. It gives me great pleasure, and I'm so humbled and privileged to do this talk on mental health and children. And I'm learning myself a lot. And thanks, Tain Marie, for giving me this opportunity, especially during this pandemic time, to talk about children and their mental health. So again, back to University of Madras. This is where my ancestors also studied. It goes like more than 150 years, I believe, or 200 years now. Okay, so it's a great privilege again to talk about mental health for the students of University of Madras, especially in CHINTHA 2020. I love this slide. I don't know who prepared this. The title, Giving Wings to Thoughts. It's such a wonderful statement, and we are all living isolated. I have to say this, in lockdown, quarantine, we are all isolated, but our thoughts are together. I believe in yoga, ekam, it's union. We are all together thinking alike. So let's fly through our thoughts. I love this lining also, this mental health for all, greater investment, greater access. So even millionaires and billionaires here are stuck. I don't want to mention the name, the one who is in the hospital right now. So for the next 2 weeks, especially during election times, right? So even though you have a lot of wealth, but it's the mental health that is very, very critical right now. So children, we all love our child. Even this time we try to go back to our childhood memories, and how a great time we all had playing outside. Even during pandemics, some children, they are trying to do virtual games and stuff like that. So uh, children are like birds. They were flying in the sky, adding colors to the clouds, sun, moon, and the stars. What happened to all these kids now? They're all stuck. Yeah. So with the lockdown, they're all inside. How do they all feel right now? Especially in the US. I don't have any data from India side. I'm sure a lot of studies are going on. But according to the American Psychological Association, during the first wave between April and May, 46% of parents were stressed out. And if you look at the pattern, compared to a non-parent, parents were quite a lot stressed out. Why? So they were all worried about getting corona by themselves or one of the family members getting it. And the government responds to the epidemic, and they didn't have a routine at all. They were trying to adjust to the new routine, and mainly for the children, doing distant or online education. And what about the basic needs of everyday living? So availability and access to food, housing, and you're all isolated. And how about access to healthcare facility? If one person is sick, how do they do that? And all the milestones. I have to mention about my own family. My daughter graduated from college, and she was supposed to have a very grand graduation ceremony, but unfortunately we had to do like a Zoom, and everything was through Zoom, and we are getting used to it. Let's see what happened in the next wave. In the second wave, 71% of the parents got worried because we didn't know what's happening to this, and they were wondering, what's going to happen to my child's, social development and their education and their long term. And they all felt, almost 55% felt, the children were starting to act out. So coming to the most important topic of the day, the suicidal ideation, thoughts, and depression and anxiety. Please make a note, when we compare the first wave to the second wave, there is a drastic increase in everything. Depressive symptoms, anxiety, non-suicidal self-injury, suicidal and suicidal plans and suicidal attempts. I've sent my slides through PDF to Dr. Thenmuri, and she'll be sharing it with you all. Please make sure you read this as a future professional in psychology, because the rate is going alarmingly very, very high, especially in the younger generation. So the age group, it goes without saying, from preteens, teens, young adolescents, and adults, and goes on. So what do we recommend? So we are all connected through the social media. There is no other way, no other go. We are all stuck in the social media, and we have to make use of this. Through smartphones, we are trying to socialize with each other, even though, like this, even this lecture, I'm living in the US, right? So I'm able to connect to you all in Chennai. We are like thousands and miles apart, but still, I'm able to see and talk to you. I imagine that I'm talking in front of you all. So this is how the life is going to be, at least for the next 2 years. And the very, very most important thing is the physical activity in addition to your routine. Everyone should have a routine to get up at the same time, and stick to a routine at least through Monday through Friday. And they find exercise is the main key to stay, healthy, not only physically, but also emotionally, mentally, and socially. So this exercise now has become part and parcel of almost all the diseases, not only physical, but also the mental diseases. I would say, especially for the mental illness. And it goes without saying, as human beings, or even animals, we need to sleep. We need at least 8 hours of sleep. I talk to my parents as well as the children, saying that, remember number 8. So you have to take 8 cups of water every day and 8 hours of sleep every day. So we all need to rest our brain and to heal ourselves. During sleep, there's a lot of healing process that goes on, not only the physical tissues, but also our brain cells. And academics, online education is the norm right now, not only for school children, but also to all the university and colleges. So we need to find out new methodology, to connect to each other. The professor talking to all the students through the media, cell phone, laptop, or Facebook Live and YouTube Live. Virtual learning experience leads to a lot of anxieties. For example, I was supposed to start this program at 8:30 sharp. I got a link, right, and it didn't really like work. So I got a little anxious myself. How do I deliver this lecture? So that anxiety is also become a part of the online learning. And separation anxiety. So most of the countries, we have lockdown and then they'll loosen up. So when they loosen up, 50% of the parents are willing to send the kids back to school, and the children are going through separation anxiety. They were all living with the parents and the family together, and now they are asked to go back to school. So the separation anxiety is also increasing, especially for the younger kids. So as time goes by, so I believe in China, it started around November. We are going to be completing 12 months of this pandemic. And in the US, 10 months. And I believe in India, more than 6 months now. So what happened to all of us? The fight is becoming uneven. So the parents as a team, they try to follow everything. So if you look at the preschool kids or the younger ones, potty training issues, And there is lack of understanding instructions, because if you don't have a routine, discipline, and structure, kids are going crazy. There's eating disorder. I have to say this, I am seeing lot of kids coming in with obesity, increase in weight, body mass index. It's like increasing like anything. This is going to have a lot of consequences in the future, like elevated blood pressure, cholesterol problems, sugar problems, and thyroid, and it goes on and on and on. So we have to address all these issues. And sleeping problem, of course, they didn't have a routine, especially in the US. After school closure, they didn't know what to do. They were living like, in India timing, kids are up all night playing games, or doing online chat and things like that. So because of inadequate sleep and inadequate rest to the brain and straining their eyes, they started becoming very aggressive, using improper language as well. So what are all the common disorders among children? This is like a general topic on the mental health disorders in children. Anxiety is the most common one we see in our practices. It's like a persistent fear, worry, about everything, play, school, or, the social situations. There are three different types, like social anxiety, general anxiety, and the OCD. And next comes the attention deficit and hyperactivity disorder. And we'll have a lot more lectures if you want to watch our YouTube channel. Right now, we are focusing on autism mainly, but we'll be addressing the ADHD as well. They have difficulty with attention, impulsive behavior, hyperactivity, and combination type. I believe I addressed this in the last lecture, for the previous batch of students. And ASD, in Project Marla, we are trying to help children with autism, because the numbers are alarmingly going up again. In the US right now, it's 1 in 54. And the last data I had from India was 1 in 66. So this is another neurological condition appearing early in childhood, below 3 years of age. And the severity varies, like mild, moderate, and severe, with they have difficulty in communication and interaction with each other. Eating disorders, I believe this is becoming more common now, especially during the pandemic. They are worried about the body image. One group of kids, they don't want to eat healthy diet, so they want to lose weight, and they eat untimely food, and they have this weird eating schedule as well. You can have anorexia nervosa on one extreme, the other extreme, bulimia nervosa, and binge eating disorders. So you have to remember all these, because now we have like a new syndrome. We're going to coin a new word in the DSM-5 during the pandemic times. Maybe it's called the corona syndrome, or whatever you call it. We're going to have combination of all these happening together, with emotional and social dysfunctioning and physical complications as well. So I want to give more importance to depression and mood disorder. Unfortunately, it's very, very sad. When I was doing my in medical school, I never saw a kid, as young as like 8 years or 9 years with depression. We thought depression is disease of an adult, not a child. In the last 3 decades, because of technology, or like, the rapid growth in science, and the easy access, the whole world in your fingertips, right? So the depression also raised like anything, and this is interfering the child's functioning in school and socializing, and bipolar disorder with mood swings, and this is leading to suicidal thoughts, and they hurt themselves. And the PTSD, it's another form of the stress disorder. Any acute stress leading to the consequences of the PTSD symptoms of, emotional distress, anxiety. They have a memory problem, nightmares, and the behavior is going quite disruptive. They become violent, and they abuse, and they injure themselves or others. And I had to include the schizophrenia in childhood also, but it's very, very difficult to diagnose in young children. What are all the symptoms? When they come in, they feel very sad, but the duration should be more than 2 weeks. and they want to, withdraw from the society. They want to isolate themselves, and they want to hurt themselves, and they think about death, and they want to hurt themselves. They come with outbursts of anger, out of control behavior. There's a lot of mood problems. They don't eat properly, they don't sleep properly, they have some psychosomatic complaints, and they don't concentrate, and they have academic problems, and they don't want to go to school. So if any child comes to a doctor, one of these symptoms are present, like you look at the child, and if the child is not sleeping, we think about the sleeping issue, right? So we have to make sure, is it only the tip of the iceberg? Let me get into the details. So let's go through the full medical examination, ask about the history, and do a complete physical, as well as lab testing, and discuss about the family history and the developmental progress. How is the child doing in school? And talk to the parents alone in private to find out what are all the concerns they have. Do they see any sudden change in the child's behavior? And we have a lot of testing. I'm sure you're learning. I'll be showing you some slides on the testing as well. So both the DSM as well as the ICD, International Classification Diseases by WHO, and the Diagnostic Statistical Manual, both describe, the mental health in children. It's time consuming to diagnose, because they don't know how to express themselves. So they have some weird presentations. So we have to spend a lot of time as a professional, healthcare professional, to find out why they are acting out like that. Is it a symptom of a medical problem or a psychological problem? So there are a lot of treatment options here. I'm sure you're going to learn a lot about psychotherapy, and you can read this in my slide that I've sent it already. I don't want to go into the details, because Dr. Tenmuri is an expert in this. I'm sure she's training you all in psychotherapy. As medical professionals, we are not trained in psychotherapy, but I came to know about few doctors after attending a webinar yesterday. Even doctors are, medical doctors are getting trained in MSc clinical psychology. I wish I had time, to do this, but I have like a long, long list in my, bucket list, in the sense, I wish I had time, but I want to learn more and more. In fact, the CBT is the one, I'm planning to do like online courses. I've registered already. Dr. Tenmuri is doing CBT for all the patients. I think she also got trained in the US. I believe last year she was here getting trained in CBT. So medications, I'll be talking more about the antidepressants in the last few slides. For ADHD, we do use medications if the child is not able to sit in one place or concentrate. If it is affecting the functioning of the child in more than 2 settings, we have to start medications. And of course, antidepressant, there are millions and millions of dollars spent on medications, especially in the US. And there are so many millions of people taking anti-anxiety medications, antipsychotic and mood stabilizers as well. But we have to put everything together to form a proper management plan. I have a small video to play. I have an expert from, let me see. Are you able to see it? This is a slide on coping.
For many of us clinicians, telepsychiatry has been a brand new frontier. I know it has been for myself. And I've had some learnings throughout that I just wanted to share with some of you. The first is, in doing telepsychiatry with families, there are so many.
You're not seeing the audio?
I'm getting audio is coming, but video is not coming. Picture, we are not seeing.
Distractions that can
Are
really
you able to see the screen, Tenmuri? Treating children and adolescents by a telepsychiatry?
No. But we can get the audio.
Okay, let me play the audio. Yes, pay attention. So basically, she's an expert.
Shanti.
And she's doing. Yeah.
Shanti,
Yes?
sorry, I think what you should do, you're playing a video separately, right?
Correct.
What you need to do is you need to stop your sharing of the PowerPoint and then share your video screen separately again. Then you will be able to see the video.
Hello, Dr. Shanti, Sairam and Dr. Vijayarani, welcome.
Thank you. Thank you. We are enjoying the fruits of your hard work.
Thank you. Thank you so much.
So let me share again. Only the video I'll share.
Yeah, only the video you share.
Can you see it now?
Yes.
Treatment goals. And so what I found is that it's important for me as a clinician to prioritize what do I really want to accomplish in this visit with this family, to let them know straight away what I'm thinking about, and to try to wrap it up by the end, because there are so many distractions over this venue that can happen, particularly when you're working with an entire family. So I like to sort of establish what we're doing in the visit pretty early on and make sure that we collaborate and we agree on that. The second aspect in working with children and adolescents is it seems very important, more important than when we're sitting in the office, to establish some rules around when we meet, what will that look like? There are just way too many distractions in the home for kids and adolescents. And so we have to start at the beginning with some expectations around, will there be any play when we're talking? If I meet with the parents, is it okay for the child to play in the background for a little bit and then have the child join? Some of our families will expect that the child will sit in a chair for the whole telepsychiatry visit, and that's very difficult when there's pets and toys and other distractions. So we've had to have a discussion, and actually we send some information prior to the telepsychiatry visit that just establishes that the family has a place that's confidential, that they can talk and not be as distracted by some external noise, etc. We've had a couple of our patients who actually meet with us in their car or in their bathroom, because that's the only room that they really have that's going to be quiet and safe and without distraction. So it's important to be able to establish that right away, as well as if the child would like to play or if they'd like to draw, to just sort of let parents know that that's okay, and to work with the family around the view of the visit so that some observations can continue to take place. I can observe the child, watch the child sort of popping about and what they're doing with their play while I'm talking with the parent. And then allowing a time to very specifically meet with the child and ask questions of the child, but then giving them some freedom to come and go is important as well. The other thing that gets in the way sometimes is just audio or video. And it's funny because I've had excellent visits with adolescents who are in their bed, and I just see their face every so often, but they're so comfortable being in their bed and so quiet and in their comfortable space that they're sharing a lot more. And so I'll ask to see their face occasionally, but that's less important than that comfort of that environment. And then there's other times when we have a teenager on screen and we're hardly seeing their face and we're hearing their phone because it's so easy to hide from distractions. So we've had to navigate how do we manage audio, video, what kind of a picture do we expect during our visits? And as things slip away, as kids get a little more distant over telepsychiatry, we just really ask them what they're about, what that's about, and make it a part of our visit, just like we would if it were happening in our office. So some of the challenges that you can sort of head off, you can do it in advance by setting those expectations, by discussing treatment course for that day, by connecting closer or further. And I found that more than in the office, I really need to have my entire focus on looking at the patient. The more I look away from the patient, the more disinterested they are. And so unlike in the office where you might glance down at papers or turn to your medical record, I really find in telepsychiatry, you need to be very on and connecting. And if you're not, you really begin to lose the engagement of the child or the adolescent. So the more you can do that also helps. So I hope these tips might help you too as you're crossing into this new frontier. And it would be great to hear your tips as you're doing this as well.
So I wanted to show this video mainly because this is a psychiatrist, who is able to do telepsychiatry. So what are all the challenges, in telepsychiatry? I'm sure you're going to start your practice soon. And as I said, COVID is not going away. In the next 2 to 3 years, we are all going to have a new era of healthcare, telehealth. So we are all starting with telehealth. We are connecting to the parents. 50% of my practice is telehealth. So we try to see only the physical, the well visits in the morning for patients and the growth and development assessment. In the afternoon, the other 50%, they come on televisit. We have a lot of challenges. We have both pros and cons. Pros, it's very, very convenient for the mothers. They love it. They're able to connect at their convenience. They don't have to drive here and they don't have to wait, in the waiting room. So they're able to connect. And we do have some technical difficulties with, audio and video, but the child is at ease. We are able to look at their home surrounding and you have an idea about, the environment, whether it's like a nurturing environment or is it like totally disorganized, it gives a better picture. So the reason again for showing this in particular to the psychology students, because you are the future. Once you graduate, you're going to start talking and connecting to all these children as well as the family through the media, like, cell phone or, laptop or computer tab and whatever. So you have to learn this new. We are old school. I believe in seeing the patients in person. For me, I have to touch the patient, I have to examine the patient to diagnose, right? But now we are diagnosing or over diagnosing, over the telehealth. So when a child some complaints of a sore throat, I give antibiotic. I'm overdoing it. I don't know whether it's like a viral infection or a bacterial infection, whether it is strep throat, but I don't want to risk it. So I want to treat the child and the parent is happy. She's getting the medicine just like that. And it's an e-prescription, goes to the pharmacy and she just needs to collect it. And we have some home delivery as well. So life has become easy. So with online shopping, you get everything. So same thing with healthcare delivery also. In the next 3 years, you're going to change, like a drastic change in the delivery system. So you better get trained. So you have to be a tech savvy. I'm learning a lot of, training sessions for Zoom and other webinars. So even though we are in healthcare, we have to be learning technology every day because, YouTube and Facebook, they are giving updates almost every week. So let's all learn together and keep up, with our knowledge on the technology as well. So these are all the insights from a psychiatrist during her tele counseling session. So this is what you're going to do. So you make sure you become an expert in this. I'm sure in the next 5 years, I will listen to one of you talk about this. I'm sure, Dr. Tenmuri will be around to include me in the lecture. So let's go back to the next slide. I'm sorry, it's stuck.
So just add on.
1 second, please.
Shanti, yeah, you can just start. See, I've signed up a course for tele-counseling because I'm planning to introduce that in the curriculum.
Okay.
Online counseling skills, because we need
awesome.
trained up for online counseling. So first, I'm signing up. I'm going to do this program through Counseling Tutor, and planning to introduce that to the students, because as you said, that's order of the day, and we have to update and get trained in that also.
Absolutely. Somehow, I'm not able to share this screen. Yeah. Are you able to see my screen? Yes?
Yeah.
Yes,
Can
yes.
you see my screen? Okay.
Yes, yes, yes.
So I would like to share my experience in the state of Texas. We have a program called CPAN, Child Psychiatry Access Program. And I'm sure Dr. Tenmuri can, come with a similar idea in Tamil Nadu. We can do it for the whole state of Tamil Nadu. So I would like to explain more about this program.
Shanti, what happened?
Maybe her line she was telling was not okay. Maybe she got disconnected. We'll wait.
Oh, she's got completely disconnected, is it?
Yeah.
Ah, okay.
Laptop also.
Tenmuri, can you hear me? Hello? What happened? I don't know.
Oh,
So
we are not seeing you. We are not hearing you. You're
yeah,
also,
Yeah,
I
we can
don't know
hear
what
you.
happens.
now,
Yeah, I don't
now
know.
you come here.
Sorry about that. Sorry about that. So these are all the technical challenges we were
Yeah,
just talking about.
of course, of
So
course.
it's okay. It's good to be back and we learned something also,
Yeah.
So
Many
I
learnings
didn't want to panic. I'm good. I'm good. Yeah. Yeah. Okay, good. So coming back to the services provided in C-SPAN. So as primary care providers, we are not like specialists in the mental health care. So with C-SPAN, we are able to connect to the professionals. We have what's called the behavioral health specialist. Like they are available 24/7. And able to screen the problem, and then the number of children who come with depression, anxiety, and the behavioral disorder, you can see here. Are you able to see my cursor? Yes.
Yes, yes.
So the big part of our practice, especially after the lockdown, we are seeing increasing numbers of depression, anxiety, and behavioral disorder. So these three are the major problems we are facing in our practice day to day. So coming to the C-SPAN strategy, So we have like child psychiatric consultation. They respond within 30 minutes and it's a free service. And if they have if they need any non-pharmacological intervention, even the behavioral health specialist can help. They have evidence-based alternatives to medication. I'll give an example with a family. If they don't want to take medicine, what can you do to help the child to get better? And they have like a full care coordination team helping with the follow-up as well. It's very, very crucial to follow up these children with anxiety, mood problems, and depression, to make sure they are all getting better or not getting worse. And sometimes we lose track, and the suicidal rates are going to go higher and higher. We play a major role in bringing down the number of cases. So let's go to the next slide. So again, so in the C-SPAN program, Taimur, you may want to, create something like this so that we can do it as a team. So it doesn't matter where the patient is, we can do telehealth consultation. So the telephonic clinical consultation during business hours, as I said, the behavioral health clinician. So they will determine if a consult with a psychiatrist is needed or not. So that's like a screening program. And the care coordination will refer these kids to a higher level, like a psychiatrist or even like super specialist. We have this community health program. And as primary care physicians, we are given training also. Once a month, we have, training given by the Children's Health. This is the Children's Medical Center in Dallas. This is the UT Southwestern Medical Center, one of the top in the country. So going to the next slide, working with your consultant. I want you to look at these 5 S's. Let me try to make it a big screen. If it doesn't work, I have to go back. These are all the technical issues we have here. Yeah, there you go. So coming to the 5 S's, safety. Is there any concern about the child's safety? Is there any specific behavior as a complaint, big complaint? And the setting, is it happening at home or at school or both? And what are the stressors at home? There is some, marital issue, domestic problems. Are there any housing insecurities or any loss in the family? I see, I don't know why, I'm seeing more preteen girls between 9 to 11 years. They come with palpitation, and the heart rate is high, and we take an EKG, or we even get a cardiology consult, just making sure there's no arrhythmia. But finally, it turns out to be simple anxiety because, she lost her grandmother due to COVID. They couldn't go to the hospital. They couldn't see the body, So she got so worried. She was not sleeping well. Her fear was that she's going to lose her mother to COVID. So it is becoming more common now. I'm seeing a lot of preteen kids coming in with, anxiety, presenting as palpitation, or, not able to sleep. And of course, the 5th one is the most important one, the services provided, how we help them get the help they need. So going back to the examples, so I have a 8-year-old kid, he has been diagnosed already, and he's on medications to improve his attention, So now they have there is no concern about the safety of the child, but he has some specific behavior, like not able to sit in class, and he has some aggressive behavior with other kids at school. So the behavior happens like in school, not at home. It's only in one setting. And there are no clear stressors, but he is doing poorly in reading. Underline, please note, he is doing poorly in reading. No other services have been tried except the medication. So here we have a child who has been labeled, with ADHD, and he's on medication. And now he has behavioral problems in school only, not at home, and he has problem with reading. If anyone wants to answer, I can take the answer. So what do you think we should do? Should you go up on the dosing of the medication, or should you switch to another medication? And if you switch, what you should give? And then do you think he needs counseling? And where should he go? And what are the testing you have to do find out the learning disability? So if this child comes to me, so the first thing I have to find out is why he was acting out in the classroom. And it's very clear that, he has dyslexia. So find out what kind of help he needs. He's going to need like special ed one-on-one, for the reading skills. So that learning problem, is coming out as aggressive behavior only in school, not at home. So why do you want to go up on the medication causing more side effects? Or why do you want to switch to another medication? He definitely needs counseling for the behavior. He needs telehealth visit with the psychologist. I would refer them to C-SPAN for the tele consultation with the behavioral health specialist and psychologist for the counseling, and will talk to the school, give a letter to the school saying that he has dyslexia and he should be treated with special education one-on-one, and make sure you follow them up. I usually see them in 2 weeks or 4 weeks. The second example, we have a 16-year-old female patient. She's failing in school, but mainly because she's skipping school and she hates school without any reason. And you have a counselor in your practice, that is the behavioral health specialist I was telling you about. And she feels that the patient is expressing suicidal thoughts. And she's worried, you should start antidepressant along with continued therapy session she's taking. And also she reports that there is a concern for her safety and her specific behavior, including depression and changes with friends, and make sure you wonder whether she's using any drugs. And there's a big stressor also, she's a first generation American and a father who doesn't want to start medication. So I would like you to retrieve the previous slide. Remember I told you about the alternative equivalent therapy, like medication. Should you send her to a hospital for suicidal thoughts? Anyone wants to answer this question? Anyways, yes, I'm worried. I'm very much worried. She's a teenage girl and she has like suicidal thoughts, and you never know. Girls, they act out, right? So definitely she needs help. And you should push medication trial with the family? I don't think so. Compliance is a big issue with antidepressant. If the parent doesn't want it, and how can you make the child take it? You cannot push or you cannot force a child or a family to take medication. But definitely we can arrange for other alternative medication. So what intervention should be the next? So the thing with C-SPAN, we call the psychiatrist right away, and they can do either like telecounseling over the media, or I usually send them to ER, because I don't feel comfortable discharging the child home, because we need to observe the child and we need to make sure we start CBT, counseling along with CBT, and make sure the child is on, remember, go back to the first few slides, she has to eat properly, she has to sleep properly, and she has to have a routine, and she should not be getting distracted. We usually do some basic testing as well. We screen the urine and the blood for any drug abuse either. So do not trust anyone. The first thing I do for the kid is, I ask her to pee in a cup. I do the pregnancy test first. So because she's like depressed and acting out, the first thing they do, they want to take a revenge on the family, right? So she's a first generation American too. The father, I'm sure this is like the typical setup where the father is the authority, and it's a girl child also. She's a teenager. So I would just make sure my physical exam is complete. I would do a pregnancy test in her urine, and I would send the urine for drug screening as well. And I will call the emergency room along with the C-SPAN, and connect to the psychiatrist and give her the presentation, and they will do further testing as well to rule out. So this could be a presentation of another medical condition also. So let me go through the types of depression here. According to DSM-5, we have to find out, how to diagnose depression in pediatric setting. As I said earlier, it is time consuming. They have like the varied presentation and the risk factors and the clinical features. And the initial assessment, you need time to complete the full assessment. And as I said, we have both non-pharmacological and pharmacological approaches in the management of depression. So the C-SPAN's program, again, we want to implement something similar to Tamil Nadu, Dr. Tenmuri. Okay, so why is it important? According to the National Institute of Mental Health, 2 to 4% of kids suffer from depression each year. And look at the next line, 4 to 13% of adolescents suffer from depression each year. So it is like, almost 3 times more, So, and these are the numbers before the pandemic. I'm sure it's going to quadruple during the pandemic once we have more studies on, depression in children during pandemic. And they have a significant functional problem in at least more than 2 settings. And this leads to lots of comorbid issues as well. They have problem focusing, anxiety. It presents as psychosomatic illness, behavioral problems, substance abuse, and of course, the suicidal behavior. So there are like different types of depression. You have the disruptive mood dysregulation disorder, major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, substance medication induced depression, and due to other medical condition, I'll address that as well, and the unspecified depression. According to DSM-5, you have to have at least 5 or more symptoms of the following. I think we mentioned it in the first few slides, and you can read in my PDF folder. Dr. Tenmuri will be sharing with you all. And the clinical features, it's very challenging for us clinicians to find out whether it's like a medical condition or a psychological condition. The mood changes, loss of interest, change in their appetite, sleep, fatigue, feeling of guilt or worthlessness, and repeated thinking, of suicidal thoughts, and then the psychotic symptoms as well. So we need a psychiatric and a general complete medical history, assess the mental status, complete physical examination. We do make sure, they are not anemic and they don't have any thyroid issues. And we look at the chemistry and the toxicology. And we have screening tools I'll be showing in the next few slides. And we have to make use of it in our practice to all the doctors as well as all the psychologists as well. And we have to assess the risk and the stresses and how to modify the stresses and how to make them function normally. So what are all the risk factors? So if you go back to the medical history, they may be like a low birth weight baby, and there's a family history of depression. It is a dysfunctional family. There's history of trauma, child abuse or neglect. There's bullying or peer issues at school. And the next point is very, very important now because it's unbelievable. After I moved back to the US, I have a handful of kids, they are confused about their own gender identity and homosexuality. We are learning a lot now. Almost all the states have, come up with a new testing, for the doctors. I had to renew my Michigan state license and I had to take a test on homosexuality. And there are so many terms used for the doctors. It is like Greek and Latin. I had to learn all about human trafficking and about homosexuality. So you guys should be, on top of these, gender dysphoria is coming to India also because they want to copy the Western world and culture. And the negative style coping with stress and history of traumatic brain injury and any chronic medical ailment. So, yeah, what are all the differential diagnosis? I don't want to go into the details. There are similar medical and psychological issues which can mimic depression. I want to focus on the screening tools. So when any child comes, typically from age 9 to teenage, we see them till 19. So we have the first screening tool called the PHQ-2. We ask about, whether they have interest in the day-to-day life and whether they feel hopeless or, feeling anxious or depressed. Those two are the PHQ-2. So just with 2 questions, you can screen them. If they don't feel, they're perfectly fine, we don't go to the PHQ 9. So this PHQ 9 takes just 5 minutes to complete. There are 3 different types here, but I'm talking about PHQ 9. This is the tool we use in our day-to-day practice. It takes just 5 minutes to go through the questionnaire, and then this we do it, even below 19. This is what we use, and it's quite free. It comes with our EMR, the electronic medical system itself. And the next slide is going to talk about the PHQ scoring and the different severity of depression. If the score is between 1 and 4, they are normal. You don't have to do anything. Just complete the questionnaire. And if it is between 4 and 5, you have to do something. And if it is between 5 and 6, you have to do something. the PHQ. Again, if it is 10 to 14, it becomes moderate. You have to start planning, treatment planning, and consider starting counseling and assertive follow-up as well. And if needed, we have to start medication as well. So coming to the moderately severe, the score becomes 15 to 19. So you have to start the therapy right away and make sure that you get started on the CBT or other psychotherapy immediate, therapy. They need medications, and they need full consult with the psychiatry and the full team of behavioral health specialists as well as the psychologist. So what is the treatment for mild? You can just talk to them about the same thing, routine, eating healthy diet, having structure, getting good night's sleep, and keep them occupied, so give them with a lot of resources, for self management. And if they are smart, they come out of it very well. And with moderate depression, you need to start medication and start therapy as well. And the same thing in severe, it goes without saying, sometimes you have to put them in the hospital for ECT as well. So this is the protocol of depression. So it's a combination of everything. As I said earlier, exercise has shown almost equal results. So if you exercise for an hour every day, you get the endorphin released into your system. So, and you will not believe, I'm promoting yoga and pranayama to all my parents and kids. I keep telling this in almost all my lectures here. I want to reinforce the fact that, our Indian traditional yoga is the best management in almost all the medical problems. So I tell them, do what is called a 7-11 breathing. They all like 7-11. So inhale for 7, exhale for 11. I take the blood pressure, it becomes normal. They feel, oh, I'm feeling much better. The mother, the patient, and myself, we count. I tell them, let's all take a deep breath, 7, inhale and exhale. Let's do it 3 times, and we are able to connect to each other also. Sometimes, the parents are like in tears. Oh, this is so simple. I didn't know this. I have to breathe. I'll be okay, And then definitely therapy plays a major role. And I'm promoting CBT, cognitive behavioral therapy. There are new methods coming up, the IPT, interpersonal therapy. I'll show you in the next few slides. So please make sure all your patients, start with a routine exercise every day. It doesn't matter. They don't have to go to gym. You just get out, look at the nature, get some sunlight, do some Surya Namaskar or whatever, just go for a walk. 20 minutes of active walking will cure most of the mental problems. You don't have to go on medications. But we do have a significant number of patients needing medications. We use quite a lot of SSRIs. I have great success with fluoxetine. It helps children with obesity as well. So we give, 8 and above. This is my favorite. And if I have to start the other first line, citralpam, pram, I usually consult a behavioral health or a psychiatrist. This is given 12 and above. These two are used very commonly in primary care practice. Very rarely we go to the second line of treatment with paroxetine, but usually I refer them. By then I do not start the medication myself. And of course, third line will be, referral to the psychiatrist, because these are strong antipsychotic drugs or lithium, or, they need like strong medications to help them. And the treatment you need to continue at least for 6 to 9 months. These are mainly for the moderately severe and the severe group of patients. As I said, it's very, very convenient to use. We start with like 5 milligram if the child is less than 12, and 10 milligram if they are more than 12. And this is my personal choice. The other medications, we rarely use it. And I have great success within 6 months, along with exercise and counseling session. Most of the kids get better, and there are a lot more medication. As I said, medication is not my first line. My first line is having structure, routine. I want to tell this again and again to all my students, so that you focus on the routine, instead of going asking the psychiatrist to give medication. But definitely medications are needed in severe cases. And I have to tell you about the medication. So nothing comes, without any toxicity, right? The main problem here, so the child who has no interest in life, very lethargic, he's like lagging behind. He doesn't even have like energy to have any active thoughts, or when you start this kid on medication, he's going to get a little more energetic. And with depressive symptoms, there is a biggest warning of committing suicide. There's a significant number who are severely or moderately severely depressed on treatment, they commit suicide. So it's so ironic to see, so you have to be very, very, very careful, and you have to monitor them very closely with frequent follow-up. So as I said, I see them within two weeks, because I feel a little jittery, right? There's something going on with mild to moderate group. So you do the test, the screening again, to see where these kids are, whether the mild is becoming better or getting worse, and call the CPAN team to get started on the therapy and the medication as well. So I have to rush through. So I want to focus on the therapy. So this is a team approach. So as Dr. Temuri mentioned, I believe in a team approach. So when you even prayers, right? So when you pray by yourself, the effect you get is like, say 25%. And if you pray with like 100 people, definitely the effect is more, the energy is more. So same thing with the team approach with the with depression or any psychological problems. So you have to involve the child who is in the center. The team includes the family and the primary care physician and the psychological team, including the therapist as well as the psychiatrist. So you have to find out, what can you do to help the child develop coping skills, and how to make the trigger. So for trivial things, they get worked up. I have these beautiful girls coming, they are like 6 feet or 5'9". They got the perfect physique. They have the beautiful skin, but her nose is a little tilted. So she feels ugly and she wants to commit suicide. I tell her, come on, you stand in front of the mirror. You should think you're the most beautiful person in the whole world. No, I want to think like that, because can I do anything about my age or my appearance? No. So it is your thinking that matters. So the trigger is very, very important. You find out what are all the triggers making them feel anxious, depressed. So as I said, therapy, combination of all these therapies, CBT, 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 very, very important. And it's not only for the child, for the whole family. It's so nice to have group sessions. So they need support groups, the parent support group, and even the child should be able to see what is out there. If they're able to see the other teenage children going through different issues, they can actually, talk to each other and tell them what to do to make them feel better. That works the best. And you need the supportive care and the interpersonal therapy as well. And so you need the booster sessions, on and off throughout, at least I would say at least for 2 to 3 years, on ongoing. And again, CBT comes with absolutely, no side effect. It works very well once the child starts doing it. There is a new concept on behavioral activation. This helps very, very significantly. This addresses the poor sleep hygiene. So remember, I'm just compiling all my main factors here. So this is like the take-home message. So make sure they all get 8 hours of good night sleep, at least 1 hour of physical exercise, and something to make them happy, whatever their passion is, the heart and soul. For example, drawing, I love to draw, and I love to play music, I love to sing. So it doesn't matter, some kind of activity where you have passion, so that is going to help you get better. And so you have to be like, everyone has a potential. I keep telling this again, we all have something hidden in us. I tell the parents to find out what the potential in that particular child, and it is for the teachers and the parents to bring it out, so that the child becomes a master of that art, and then improve the social and the other skills as well. So once you help the family, so it becomes like, a fairy tale. So this is what we want in all the families in the whole universe, and we play a major role in making them live a fairy tale. Thank you so much. Do you have any questions? I'll take it. I can't hear you, Tenmuri.
Yeah, I think the group has muted. Now can you hear me?
Yes.
Thank you so much for the wonderful session. It is really awesome. Almost you covered very beautifully. You covered all the every part of it, especially to the matching to the theme, access for mental health and reaching. So in fact, you even covered the telepsychiatry and tele-counseling part of it, and many new ideas also you given. Wonderful it is. It is very, very useful for the students who had attended this session. I think it's very integrated and comprehensive talk by you. Thank you so much. Especially the CBT, the insistence on being a, I mean, a medical person. You are including the CBT, exercise, and pranayama. Well, I think that is what is going to work wonders. I also see a lot of success when I include pranayama and exercises. Nowadays, my counseling also is including. Nice, thank you very much. Any questions? Because she has to leave for her work. You will have many questions. Anyway, we'll see how to attend. You can also type in the chat.
Yes, I'm seeing some questions. Shanti, you had questions? Shanti Sairam?
Yes, Dr. Shanti?
Yeah, I typed it. No, can I ask just a quick one?
Yeah, of course.
Yes,
No,
please.
I know. See, I'm completely out of child health. I am not familiar with them at all. No, for a general parent, let's say they have a 5-year-old or a 6-year-old child. How do they recognize that this child is anxious or depressed, or do these kind of mood problems affect 5-6-year-old children? Does it exist? If so, what are the common things that they would present with? I mean, we can, there are children who can vocalize, right? But these children between 5 and 10, they can be irritable, they can be angry for various reasons. What is the criteria? What is the threshold? When should the parent come and approach you? When should they come to a pediatrician saying that, I think my child is not well. I think my child, because physical ailments you can see. These kind of mental ailments you cannot see, right? When do you think mother of a 5-year-old, let's say, should come and approach you? What would be the features that you would see as a change that she should seek medical advice?
That's a very good question because it is like the most common presentation in our clinical practice. So the answer is yes. So for example, I'll just give you an example. I had a 5-year-old, a girl child. She was acting out, temper tantrums, crying a lot. The father brought the child to the practice. I've never seen the father. So I asked the father, where is the mother? So he said, mother is not in the picture anymore. So we know very well, she got the separation anxiety because mom is not there. She has behavioral problems. So this is just an example because it's quite obvious. So to answer your question, Shanti, there are like different presentation. We have what is called, quote, normal problems with toddlers. We call them like terrific or terrible toddlers. This starts from age like 9 months to, that's the earliest I've seen. They can sense the mother. If mother is not happy, the child is going to cry a lot. Child is going to throw up also. Even vomiting could be a symptom of anxiety or other behavioral problems. And in toddlers, there's a big list of behavioral problems. Not only the 5-year-old, I have like 2 or 3-year-olds coming with lots of temper tantrum. The tantrum is there's like a limit for a toddler. If it is becoming more often and if the severity becomes more, that's when we have to intervene. And number 2, any sleep problem. So anything lasting for more than 2 weeks, if it is a new behavioral problem or the previously existing behavioral problem which is getting worse, we have to go through the full history. Or it could be a psychosomatic also. Remember, the 5 to 10-year-olds, they cannot express themselves. They come with stomach pain and they have some behavioral problems. They tend to urinate or defecate in appropriate settings just to show their behavior. So all the behavior, whatever you tell me, all the behavior. I had a beautiful slide in my presentation last time. It's like come with a big tag here, HELP. Shanti, are you listening? So HELP.
Yes, I am.
So
I am.
simply because they need help. You tell me, it doesn't matter crying, throwing a fit, having a meltdown, not sleeping, not eating or overeating, constipation, diarrhea, even like, the preteen girls can come with, the seizure activity rolling up, attention seeking behavior. The list is like a very, very long one. So we look at the pattern, we look at the duration, and you have to get into the full family situation, the environment, any change in the lifestyle, anything new, any stressor, any triggers. So it is time consuming. Yes, it is going to go up like anything. So watch out, all the both healthcare professionals as well as the mental health professionals. You have to look at one symptom. For example, a child is coming to your clinic because child is not eating. So the loss of appetite could be from so many reasons, but we as healthcare professionals, we want to rule out medical problems first, the treatable problems. So child is not eating because child is, teething, or the child is constipated. That is very, very common. Constipation is the most common reason here. So you have like, bowel obstruction. So the child is like constipated so badly, soiling the underwear, so you cleanse the bowel. You give them like a laxative or a suppository. You cleanse the bowel thoroughly and you give them some stimulant, appetite stimulant and multivitamin, child is going to start eating better. So that's from constipation. It's a simple problem. But with constipation and not eating, it's a behavioral problem. It's like vice versa. So you have to find out whether constipation can loss of appetite with the behavioral problem, or constipation can be a problem solving too. It's a puzzle. It's a big challenge. Yes. So in our practice, it's a big challenge for us. As you get experienced, you tend to think about a lot more. You cannot simply say it's a functional or a psychosomatic. In our training, I'm sure all of us learned the psychosomatic is last in the list. We want to find out the treatable causes. Is the child anemic? Is the child has thyroid problem? Does the child have urinary tract infection? It is also common. So constipation, UTI, stomach pain and not eating. So there are so many varied presentation. It's like a big ocean, with symptoms. So it's up to the doctor to find out what exactly is the bottom line cause. Unless you fix, so noi nadi, noi mudal nadi. So you have to find out that primary cause. Unless you fix it, that child will keep coming back to you again and again. So if a child is like a frequent flyer to your practice, I stop. I take time. I tell her we have to do some testing. So feel free to get a consult with a GI specialist or any other behavioral health specialist to find out whether it is a primary reason or a secondary reason. I hope I answered your
To add
question,
on,
Shanti.
it is also called as mass depression. Children and teens, they don't express the depression in the similar way like the adults. It's
Yes.
usually the aggression or a psychosomatic. So we can identify and it is possible. Just to add on to Shanti.
Yeah,
I
I'll
think
take two
again
more
I
questions, then I
want
have
you
to
to
leave.
know whether you have time. I don't want you to get late.
Yeah, I'll take two more questions and I'll leave.
So,
Ma'am, I want to ask, this is from Monisha Mohan. Depression can be cured without medication. I don't want to use the term cure. For certain illness, we never use them, like autism, ADHD, even for depression, so some problems are lifelong. I will not use the term cure. We can treat depression without medication. Yes, you can put them in like a CBT program, counseling, the routine, and make sure they're sleeping well, eating well. And now I'm promoting art of living and yoga, Isha. And I'm promoting, for the Indian crowd. And you should come and see the temples here. How many Westerners are chanting our Vedic mantras so well. So that is for Monisha. And Shiba Gato, some sensitive children remain quiet and cry in silence without letting anyone know that they cried. And the next time you see them, they will be smiling around before everyone. How serious a concern would it then be for parents and family matters? It's a big problem, Shiba. So, how did you know about the child crying in silence? So, the parent noticed it. So, Shiba?
Yes, ma'am.
So how did you know about the child, crying in silence? Did the
Ma'am, it's
mother tell
actually,
you?
yes, I know of her through a personal experience of a
Okay.
relative.
Okay, okay. So it is a big yes. Yes. So you have to talk to the child alone and the parent alone. And sometimes the first thing I do is, I talk to the parent why they are here and then talk to the child in front of each other. And then I make the child leave first and then talk to the parent and find out any acute stressor in the family. And again, duration is important. How long this is going on? Has it been more than 2 weeks? Has it been consistent? What is the change in the life recently? And if you let the parent leave and then bring the child back, it's like a mystery box. If you're able to connect, so make sure you touch the shoulder or shake hands or give them a hug. You have to empathize and make sure you connect. Even in our CME training now, they are asking us to be more empathetic to the patient and the parent, and they're asking us to touch the shoulder or touch the hand, tell them we are here to help you. It's confidential. Until 16 years, I have to reveal this to the parent whether the child is like in a condition where he or she can hurt himself or herself. And above 16 years, it's confidential. So it's between the provider and the patient. So we have to document everything, and we have to make sure the child is going for counseling. So underlying problem for crying, it could be like anxiety, or it could be a mood disorder, or it could be a depression. It could be a major depression. So the child needs help, period. The smiling is like fake, just like wearing a mask. Yes. I'm sorry, guys. I have to
Thank
go
you so
now.
much, ma'am.
Yeah, it's 9:45. You're welcome, Shiva.
Thank you, ma'am.
Okay, if you have further questions, you can email it to me. Dr. Temuri will share my slides on my email as well. Okay, thank you so much.
Thank you, Dr. Shanti, for the wonderful presentation. I think students really benefited and looking out for more, so we may trouble you more for any further sessions. Not very often, because we need your expertise, knowledge, and experience in sharing this very beautifully. Thank you so much. You can leave.
Thank you.
Okay, I think I should have my vote of thanks, and also to add on to Dr. Shanti's about this crying child Shiba experience, expression of whatever problem they are going through or the feelings is very, very important. See, if it is not possible to go to a therapist, or you're not able to help her, making them to go to a therapist, at least simple mandala drawing, something mindfulness art, some kind of expression will help the child. No, so you can know, as a student of psychology also, I think this, but absolutely whatever the problem or the perception the child is going through should be expressed. So you can try all this. Definitely, this psychotherapy will definitely help I don't know, whoever is going through this kind of problem, you can help them. Integrated psychotherapy, integrating with mindfulness and like adding breathing exercises with the art and whatever art they like. No, but absolutely it has to be expressed. As Freud says, just bringing it to the conscious level itself is a cure. Thank you, all of you. With this, we conclude this session of our second webinar. We will meet in the third webinar. Thank you. Good night.
Thank you, ma'am.
Thank you, ma'am.